Thanks for rejoining us. So, as you just heard, there have been some really significant changes in office coding using E&M codes as of the 1st of January of this year. And it's really critical that those of us who do reproductive healthcare know exactly what those changes are so that we can be compliant with what payers are expecting of us. Now, I certainly track this in California, and I know that our state Medicaid program is just starting to implement the new rules. So keep track of what's going on in Tennessee, both in Tennessee Medicaid and then some of your other payers as well, to see when they're going to start this. So next slide. Brooke is going to help me out again with advancing. I don't have any disclosures that are significant for this talk. Next. And here are our, excuse me, our learning objectives. We're going to talk about CPT codes for office procedures, a lot about these new rules for E&M coding as they relate to total time and medical decision making. And then one of our case studies will be about a well-woman visit and how to bill for a checkup visit or a preventive services visit. Next. Okay, so let's start with a couple of fundamentals. Next. All right, what are we trying to do as clinicians when we check off what used to be called the encounter form or the super bill? Nowadays, this is something that is probably integrated into your electronic medical record, where you click on a particular level of an E&M code and you click on a particular ICD-10 diagnosis code. But however you do it, whether it's with paper or whether it's through your electronic medical record, from the provider point of view, what we're trying to do is to help our biller put together a standardized bill for services that are given to a patient. Now, standardized is important because of the fact that for the most part, the codes that we use to submit to payers, whether it's a state Medicaid program, a state family planning program, a commercial health plan, and so on, they're a nationally recognized code set. Now, it is true that each individual payer may have a smaller set of codes that are very specific to them. That goes by the name local codes. But for the large majority of codes that you're going to be using, they're the same in Tennessee or Georgia or Maine or Florida or wherever you happen to be working. And so we send those to the payer in order to pay for our services. Now, what the payer does for that with that information is a couple of things. Number one, they figure out how much to pay your program for the services that you provided. That's based on something called a rate schedule. So for every CPT code, for every E&M code with a given payer, they will pay you so much for having provided that service. Now, oftentimes you can actually go onto a website and find out how much that particular service will reimburse your practice if you want to know. So, for example, if I'm curious what a colposcopy is reimbursed in the Medicaid program in California, I can go straight to their website, put in a CPT code, and I can tell what the reimbursement rate is. And that's true of most state Medicaid programs. However, with private payers, with commercial insurance, oftentimes their rate schedules are confidential. And so you're not quite sure what that health plan is going to pay your practice. Your CFO, your chief financial officer, might be able to find that in the contract, but as a clinician, you won't know that. So number two, they use codes, as you'll see, to try to ensure that the services that you provided and that you're billing for were medically necessary. The third thing they're going to look for is whether or not what you're billing for is actually a benefit of their health plan. So an example of that might be, again, I'm going to give you lots of California examples. I'm sure they're similar in Tennessee, but our state Medicaid program is quite generous, but one of the things they don't pay for is infertility services. So if I were to have an office visit, give an ICD-10 code that has to do with infertility, they're going to reject that payment for that, not because it wasn't medically necessary, but simply because it wasn't a benefit of the program. And then last, they're expecting that whatever we submit as claims or bills, same thing, will be supported by documentation in the electronic medical record. Next slide. Now, the most important way to remember this as clinicians is that whenever you're checking off those boxes on the encounter form, What you're doing is telling a story. And the story that you're telling is actually to your biller. And then the biller is going to be the person who then tells the story to the payer, to the health plan. So remember when we were in junior high school and remember or how we learned how to write a newspaper article? It was the what, the why, the where, the how, and so on. So in this particular case, the what are the services we performed. The colposcopy we did, the endometrial biopsy we did, the IUD insertion we did, that's indicated by a CPT code. Another service that we've done is the office visit itself. That's indicated by an evaluation and management code, what's abbreviated as an E&M code. We also will provide drugs on site, and at least some clinics do that. Others just rely entirely on pharmacies. And we also provide supplies. For example, an IUD insertion kit or an implant insertion kit is a kind of supply. Or if you give someone 24 condoms when they leave, that's a supply that you can bill for. Those codes come from a different book called the HCPCS, which is abbreviated HCPC. And I'm going to give you some examples of HCPC codes in a few minutes. So that's the what you did. The next is the why you did it. And the why you did it is based on a diagnosis. Diagnoses, of course, come from ICD, the International Classification of Diseases, in its 10th edition. And then finally, in some cases, you have to give an additional explanation about something which is unusual. And to do that, you use a 2-digit modifier. And we'll give you some examples of modifiers. They come from the CPT book. So next. So just remember, when you're choosing your codes, in order to establish medical necessity, for every what, there has to be a matching why. So I'll give you a quick example of that. Let's say the what was a colposcopy. And let's say by mistake, you put the why was a ICD-10 diagnosis code for the fact that the person was a type 2 diabetic. That might be entirely true, but that was not a reason to do the colposcopy. So there are a certain number of ICD-10 diagnoses, about 15 altogether, that match up with the CPT code for a colposcopy. So the what CPT code has to match up with one of those 15 different options for the why, and then the claim will pay. Otherwise, if they don't match, then it's going to be denied. Now, with some payers, they will actually tell you for a given CPT code, what are the acceptable matching ICD-10 codes. But you usually have to do a fair amount of sleuthing to find out what that is. Next. And then, as I said a moment ago, if there's an unusual circumstance, you explain that with a 2-digit modifier. Next slide. Okay, this just has a little bit more detail about where these code books come from. So the medical services you perform come out of the CPT book, which stands for Current Procedural Terminology. That's developed and maintained by the American Medical Association. Next is are the diagnoses, the International Classification of Disease. That is developed by the World Health Organization, but in the United States, it's maintained by the Center for Medicare and Medicaid Services, the national office, basically, in Health and Human Services that is responsible for the federal Medicare program and paying for state Medicaid programs. And then for medications and supplies that are provided in the office, they have to be administered or dispensed in the office. Those are the HCPC national codes that I mentioned a moment ago. They're developed and maintained by the Center for Medicare and Medicaid Services. Next slide. Okay, now some examples of CPT codes, and you'll be seeing these in a few minutes when we get to the case studies, there are hundreds, probably thousands really, of procedures that are listed in the CPT book. There's a whole section that has to do with obstetrics and gynecology of maybe 20 pages or so in the CPT book. Most of them are gynecologic procedures. Obstetrical services has about 4 or 5 pages rather. But the kinds of procedures that we'll be doing are IUD and implant placements and removals, lesion removals, which by that I mean vulvar biopsies or wart excisions, that sort of thing. Another part of the CPT codes that we would be billing for are point of care tests, also referred to as office tests. So any laboratory test you do in the office, like an office pregnancy test, microscopy of a vaginal discharge, a rapid HIV 1 and 2 test from saliva, for example, if it's done in your office, not in a lab, is billable. The same is true with diagnostic imaging, which for us would be office ultrasound. Also, the definitions of all the E&M codes for office visits are a part of the CPT book, as are the modifiers. And then, as I mentioned a moment ago, any drug or device that we administer in a clinic comes from the HCPCT codes. Next. All right, so here's actually a fairly comprehensive list of the CPT codes for contraceptive procedures. We don't do diaphragms or caps very much anymore, but the next two are about inserting an IUD and removing an IUD. The next 4 or 5 after that are related to either inserting or removing or both in regard to implants. And then 96372 is about doing an office injection, which in our case would be Depo-Provera DMPA, or maybe a ceftriaxone injection for gonorrhea. Next. Okay, now I told you I would tell you a little bit about modifiers. So there are about 80 modifiers altogether. There are only about 5 or 6 that we'll use in family planning. So one of them is a modifier 25. What that tells the payer is that you did a procedure and you did an unrelated office visit on the same date of service. Okay, and I'm not going to give you an example now, but we will do a number of cases that show you how to use a 25 modifier. Next slide. Another modifier that we use fairly frequently is a 51, and that's when we do 2 procedures on the same day. So let's say, for example, in the case of an IUD, removing an expired IUD is one procedure, and then replacing that with a new IUD is a second procedure. And so when you put 2 or more CPT codes, the second, third, and fourth CPT code all have to have a 51 modifier, saying that it's a separate procedure than the first procedure that you did. And then 95 we'll talk about a little bit, which is a telemedicine visit. So if you're in a circumstance where you are able to have an audio-video hookup, where the clinician's, let's say, in the clinic or at home, and you're interacting with the patient in a telemedicine visit, you would bill that with a standard E&M code, but you put a 95 modifier on that, which tells the payer that this was not face-to-face in a clinic, but it was done as a telemedicine visit. We have one example of that as well. Next. Okay, so here are some examples that I was telling you about earlier of HCPCT codes. And as you can see, the first one has to do with paying for the Depo-Provera fluid that you inject into a patient. The next 6 or 7 have to do with different types of IUDs. And you'll notice that every specific type of IUD, Kylena, Liletta, Paragard, Skyla, and so forth, all have their own unique J code, which is a type of a HCPCT code. And these are critically important because when you think about it, when you do an IUD placement or an implant placement and you're being paid by the payer, this is the one that has the highest dollar amount. Of course, it doesn't necessarily mean it's profitable, but if you have to pay, let's say, $400, $500 for a Mirena when you buy it, let's say through the 340B program or through some other purchasing program, you want that payer to reimburse you for that. And to do that, you have to use the correct J code. And then if your clinic supplies other kinds of contraceptives, you can hand patients vaginal rings or a patch, like a Xulane patch. Then they have their own unique HCPCT codes as well. And then the one at the very bottom is for the insertion kit and supplies of doing an Eskimont placement. Next. Okay, now just a little sidebar, and I'll try to do this very quickly, is to remind you that being really accurate in how you code your diagnosis codes, the reason for the visit, is really critical. Okay, and the reason why is obviously you want to establish medical necessity in the claims that are being submitted so that you'll get paid for the work that you do. But those ICD-10 codes are used for lots of other reasons. For example, health plans use them for case finding. Let's say Tennessee Medicaid wants to do some sort of project with people who have asthma, for example. They're going to go through hundreds of thousands of files looking for ICD-10 codes that have to do with asthma to identify who the asthmatic people are in their health plan. They're used for public health statistics. They're used for what's called severity risk adjustment, which primarily has to do with how primary care providers are paid. In other words, how sick or how healthy are the people in a given practice. They're used in many cases to measure your productivity in lots of either primary care offices or multi-specialty offices. The way that clinicians are paid for what they do is a certain amount of their paycheck is the same from month to month. But another part of their paycheck is based on how many patients they've seen, how many procedures they've done. Those are called RVUs, relative value units, and those come directly from the E&M codes and the Cpt codes and some of the ICD-10 codes that you submit. So it may have an effect on how much you're actually paid. And then, of course, if you do it wrong, your claims might be denied. And beyond that, if you incorrectly say that a person has a particular disease that they really don't, that could follow them for the rest of their life. So those are all reasons why you need to be really accurate in choosing the right ICD-10 code. Next slide. Okay, now the last thing I want to mention about ICD-10s, and this also relates, by the way, to some of the CPT codes and the HCPC codes. Excuse me, more and more we are being measured or graded in the quality of work that we do in our practice. Okay, and you probably know about some of those metrics already. One of the oldest are called the HEDIS measures. There are 27 different measures that have to do with the quality of primary care services. There are 3 now national family planning quality metrics that come from ICD-10, CPT, and HCPC codes. And then there are other quality metrics that come from your various commercial health plans or your state Medicaid program. What those various groups do is they figured out a technology for looking at the various, particularly ICD-10 codes that come from claims in your practice. And from that, they use technology to come up with a report card about how well you're doing in comparison to other providers. And if you're doing particularly well, your practice might get a cash bonus. You might get an A on your report card in comparison to your competition and so on. On the other hand, if you do really poorly in these quality metrics, then your payers, or let's say, it could be a state family planning program, for example, might single you out for some kind of remedial action or sanctions, or maybe even disenroll you. So it's all the more reason for accuracy, because your report card in terms of how well you're doing in your practice, how well you're doing or how poorly you're doing, actually comes from your claim status. Next. Okay, so let's talk about now the nuts and bolts of billing. There are lots of different types of E&M visits, but it's really the first 4 that we're most likely to use in family planning. It's number 1, an office visit. That's the standard contraceptive or STD visit. Number 2 is preventive medicine services. That's the standard checkup or well woman visit, or well male visit for that matter. Less commonly, payers will actually accept E&M codes for individual counseling. And then there are some codes for telemedicine, and those have been recently expanded. The other ones are really related to what certain specialists do as consultations, codes that are used in the hospital or skilled nursing facilities. We won't talk about those today. Next slide. Now, among those first 4, okay, what I've included are the code ranges for you. So remember that we have E&M codes that are for problem-oriented visits. That's a person who comes in with a symptom or a complaint or a need for birth control, or because they have assumed that they've maybe been exposed to an STD. Those are codes you're very familiar with, 99202 through 205 for a new patient, 99211 to 215 for an established patient, okay? Then we have that followed by the preventive medicine services. That's a checkup visit. That's based on 2 things. Are you a new patient or an established patient, and what's your age? Then the next are preventive medicine counseling codes. Those have to do with specified time intervals, and they include things like smoking cessation counseling or substance abuse counseling that you do. So what you see up in the right-hand corner, although it's hard to see, that should say only. In this big package of changes that happened on January 1st, it's only that very first bullet. It's only the problem-oriented visits. that have changed. And of course, I'm going to go into a fair amount of detail to tell you how it's changed. Next slide. There we go. Okay, so let's do just a very quick before and after. The way that you assigned an E&M level before January 1st of this year, so going all the way until December 31st of last year, 6 weeks ago, next slide, is that we build an E&M code on the basis of one or the other of criteria. One criteria were what were called the 3 key components. I'm sure all of you know about that. You've used it and you're familiar with it. So the 3 key components are history, physical exam, and medical decision-making. So you looked at a score for history, a score for physical, a score for medical decision-making. You drop that into a template and you figured out an E&M code either for a new patient or an established patient. Or alternatively, you use time. Time could be used based on face-to-face time between a patient and a clinician, but at least half of that visit had to be spent in counseling. Okay, it was one or the other. And the reality is that in most family planning clinics, most visits were built on the basis of time. Just because, you know, as things have evolved over the years, we're doing less and less of physical exam, more and more of medical decision-making and counseling and so on. And so therefore, you actually could choose a higher level of E&M code based on time. So that's the way it used to be. Next slide. So what changed on January 1st? Next slide. So what changed after years of getting ready for this is that there are now 2 ways of selecting an E&M visit. One is called total time. It's different than what we used before. The other is called medical decision making. And even that is a little different than what we used to do before. And of course, I'll tell you about both of them. The next thing that happened is that they deleted one of the E&M codes, which is 99201, which is a new patient, a straightforward visit, meaning like a 5 or 10 minute straightforward new patient visit. That is no longer an acceptable code, okay? And I'm sorry that this is so wordy in the next bullet, but basically what it says is it is no longer important from the point of view of billing of how much you do in terms of history and physical examination. Of course, you got to figure that out in terms of what constitutes good patient care. You have to take a comprehensive history. You have to do a certain amount of physical assessment in some cases, not in others. But that's kind of up to you with an individual client, and it no longer has any bearing at all on billing, on coding or billing in terms of what you do in the history and physical. That's a huge difference from how things used to be. Next slide. So now let's talk about those in more detail. Oh, the other things, just to make sure that the time intervals have changed with each of the codes. They have removed that 50% threshold for counseling time. So now you can bill total time, whether there was just 10% of the visit was counseling or 90% of the visit was counseling. It doesn't matter. And then we're going to talk in just a moment about all the things you need to include when you calculate how much face-to-face time. Next. Next, yeah, there we go. Okay, so here are the new time intervals. All right, so the box on the left has to do with new patients. Remember that a new patient is someone who's never been seen in your particular clinic or someone who has not been seen in at least 3 years in your particular clinic. An established patient is someone who has been seen in your particular clinic within the last 3 years, okay? And these are the new time intervals for new patients and established patients based on these new definitions of E&M code. And they are quite different than the intervals that are used before. So be sure you update your intervals, your time intervals. Next slide. Now the next thing that's important is what can you count in time? This has got to be posted on the wall in every exam room or at every computer terminal so your clinicians can remember all the things you can count in time now that you couldn't count before. So number one is typically before we see a patient, we go to the EMR, we look at her the note for her last visit. We might look at some laboratory results. We might look at the result of an imaging test or a biopsy that she had. So the time you take to prepare to see the patient can be counted. Number two, the time it takes to obtain a history or to review a history that someone else took. So if you have a medical assistant or a counselor who took a history, now as a clinician, you take time to review that history, you can count that time as well. Next is the time it takes to perform an exam or evaluation. Next is to counsel and educate the patient. And if the patient brought a family member or a caregiver, you can count the time of educating them as well. And then look at the next one, the time it takes for you to document that in the patient's health record. So if you spend 10 minutes typing into the EMR about this particular visit, you count that time as well. In addition, you can count the time of independently interpreting tests. Now, that doesn't come up for us very often. But what that means is that if the patient had an ultrasound in radiology, and you know how to read ultrasound, you pull up that ultrasound image and you interpret that yourself beyond what the radiologist did. You can take that time into account as well. And then any care coordination that you do in terms of like filling out a referral form or a consultation form or calling up another provider can be counted as well, okay? So I hope you see how hugely different this was than before. Previously, you only counted face-to-face time with the patient and it had to be 50%. Now you can count all of these different things in time, and so you will be spending, or you'll be having much more, you'll have longer time intervals than you did before. And by the way, it goes without saying that that time total has to be noted somewhere in your note, like 35 minutes with this patient to perform these things, okay? You can't just like pick an E&M level without actually documenting what that total time is. Next slide. Okay, now the next thing that's changed is that if you don't use time, you have to use what's called medical decision-making. So medical decision-making is based on three different things. Next slide, or hit again. There we go, okay. And so from used to be the old definition of medical decision-making, to is the new definition of medical decision-making. So the three so-called elements of medical decision-making are, number one, how many problems does the person have on their problem list and how complex are they? Number two is how much data, like laboratory results, did you have to review and analyze? And number three is how sick is this patient relative to the risk of complications as a result of the way that you manage the patient. So we'll go through some examples of all three of those. Next slide. And I know these are like very busy tables. Believe me, I'm not going to read everyone. Okay, so the first element of medical decision-making is the number of problems. They fall into four categories, as you can see: minimal, low, moderate, and high. So minimal means just one self-limited problem. That's pretty easy. I'm here because I'm burning when I urinate. Turns out the person has a bladder infection. That's a minimal. Next is low. And for most of our visits, it's going to be one acute, uncomplicated illness or injury. So that could be, for example, I'm here for contraception. All right. Next is moderate. And of the various scenarios in moderate, the one that we're most likely to use is one undiagnosed new problem with an uncertain prognosis. So good example of that is I'm seeing a patient with pelvic pain, relative to the last discussion. She has a copper IUD. I'm really concerned that she might be pregnant or even have an ectopic. So that's going to take me some time to figure that out. And that's going to end up being a moderate level in this first element, which is an undiagnosed new problem with an uncertain prognosis. And there are certain things that won't help us very much that are considered to be a high number of problems. So that's the first column, so to speak, the number of problems. Next slide. Skip over this one. Great. Okay, here's the second column. And this has to do with the amount of data that we had to review. So first is minimal. We didn't have to review any data at all. The second is limited. And it's any combination of two from reviewing prior external notes. That means a note from a provider outside of your practice. So the patient was seen in the internal medicine clinic. and you're in the family planning clinic reading that note from the internal medicine clinic counts, but not if your colleague wrote a note 2 weeks ago for the family planning clinic. Number two is reviewing the results of each unique test that the patient has. And number three is ordering of each unique test. So in this limited category, if, for example, a gonorrhea test is ordered, a chlamydia test is ordered, then that meets the criteria for limited. And a moderate is a combination of any three of review of external notes, reviewing the results of each unique test, and ordering each unique test. Next slide. Now, this is the part that gets a little complicated. It took Anfin and I a while to get this figured out. But here's how this works for that middle data element. And that is, if you code and bill for a point of care test, you can't count that as data at all. So if you order a pregnancy test in your clinic, office pregnancy test, and somebody performs it, it turns out to be negative, you don't get any, and you bill for it. Of course, you get paid for doing that pregnancy test, but you can't count the ordering or the review of the results of a test that you bill for in your clinic in this data element. Number two is that if you order a test, it also includes you reviewing the result of that test. So let's say 2 weeks ago, I ordered a gonorrhea and chlamydia test. I'm seeing the patient today, and I can see the results are both negative. I can't count those as having reviewed that test result because I was the person who ordered it in the first place. So ordering it and reviewing it only gets 1 point. Okay, so another way of saying that is that to get credit for review of test results, it can only be counted for tests that you didn't order. All right. And then the last point that these rules have is that each unique test has its own CPT code, but if you order a panel, let's say it's called a metabolic panel that has like 8 different components to it, you don't get to count all 8. That panel counts as one unique test. Okay, the dandelion is a wheat, by the way. Okay, next slide. All right, now we finally get to the third data element, or the third element, which is the risk of complications. So minimal means, there's really no risk of complications for what we're managing. Low means a low risk of morbidity from additional diagnostic testing or treatment. But for moderate, I want you to notice the first bullet, which is prescription drug management. So if you prescribe pills, patch, ring, and IUD for a patient, it automatically counts as moderate in that third category of risk of complications. Next. This will become much clearer once we do our cases in just a few minutes. All right, so this is a really important slide because what it tells you is if you're going to use medical decision making, the first column is the number and complexity of problems. You choose one of those 4 scores. Next is the amount and complexity of the data. Choose a level. The third column is the risk of complications. Choose a level. So what you can bill for is the best of 2 out of 3. So let's say, for example, it's a low number and complexity in the first column. It's a limited complexity of data reviewed in the second column, but it's a moderate risk of complications in the third column because you prescribe birth control pills. Okay, the best of 2 out of 3, this is referred to as low. So if it's a new patient, that's a 99203. If it's an established patient, it's a 99213. Okay, so you choose whatever is the highest of 2 out of 3, and that becomes your E&M code. Next slide. Okay, this is just a summary of another way of looking at this, basically. New patient on the left, established patient on the right. Remember that a 99211 hasn't changed. That's basically an RN visit without the patient seeing a clinician. And then it kind of gives you an idea of the rest of these codes in terms of what the correlation is between medical decision-making complexity or how many minutes you've spent with the patient. Next. Okay, all right. So 1 or 2 last points and then we'll get to our cases. Another thing that I want you to really sort of take home from this is that whenever you see a patient, you fill out the encounter form, that there's actually a framework of the various boxes that you have to check. And there are basically 6 boxes that you need to think about. First box is, did you do any procedures? as indicated by a CPT code. So that might be an IUD placement, an implant placement, a colposcopy, endometrial biopsy. Those are all procedures. Next is, what about drugs and supplies? Well, that would be an IUD placement kit, an implant kit, the condoms you dispense, the spermicides you dispense, or if you can send the patient home with 13 packs of birth control pills, that fits in this category too. So how do you bill for those? Your biller's going to do it. You're not going to do it, but they are either going to use the HCPT codes that I told you about earlier, or they're going to use a code which is called an NDC code, which stands for a National Drug Code. Sometimes the payer wants that instead. The next category is, what did you do as point of care test for either lab or imaging? So you might have done an on-site lab test, like a pregnancy test or a microscopy or a pH, okay? Or you might have done an office ultrasound, which could be abdominal or vaginal. Next is, what's the E&M code for this visit? It's going to be either problem-oriented or a checkup visit. And does this need a modifier or not? So these are all the whats of what you did. And then the bottom is the why. It's an ICD-10 code, which usually will start, in our case, in reproductive healthcare, with the letter Z, the letter N, or the letter O as in olive. Next. Okay, now we get to our case. So our first case is Janie. Janie's a 19-year-old established patient who presents with concerns about having acquired a sexually transmitted infection, and she wants to be tested. So she got STD and contraceptive counseling. And at the end of the contraceptive counseling, she said, you know what, this Skyla sounds really good to me. I'd like to have an IUD, and if you can do it, let's do that today. She had an office urine pregnancy test that was negative. She had a point of care HIV test using a saliva sample, again, because of her STD concerns, that was negative. And a vaginal sample was sent to the laboratory for gonorrhea and chlamydia, because she's 19 years old and she hasn't been checked in the last year or so. It has nothing to do with the fact that she chose an IUD. It's time for her annual chlamydia and gonorrhea test. So a bimanual exam was performed. The IUD was easily inserted. The clinician decided to do a pelvic ultrasound just to check and make sure that the IUD was in the right place. And here are the time frames. The face-to-face time with Janie was 18 minutes. The total time, if you take into account the review of the chart, all the conversations with her, the time it took to write your note, in total was 26 minutes. So the 18 minutes is a subset of the larger 26 minutes of the total time. Next slide. Okay, so let's talk about how to code this. All right, so we did a procedure. The procedure was her IUD insertion. And when you check off the CPT code for IUD insertion, it has a number of things bundled within that CPT code. The history you took about what method she wanted, or about using the IUD, I should say. Checking whether she's currently using any medications or has any allergies. Giving a local anesthesia if it's necessary. It wasn't in this case. Performing the procedure, which was her IUD insertion, and then watching her for 5 or 10 minutes afterwards. All of those are included in the CPT code for the IUD insertion. None of them can be like split out. Okay, so that's her procedure. Next slide. Okay, now the thing is that, remember, Janie also got a lot of other services performed. We gave her STD counseling. We took time to discuss all the different methods of contraception that are available. She just didn't come in and say, I want a Skyla. She wanted to know all about every method. So this comes directly from the American College of OBGYN coding department in their LARC quick coding guide. And what it says is, if a patient comes in and says, I want an IUD, followed by a brief discussion of here are the pros and cons, you have her sign the consent, you do the IUD placement, you can only bill for the CPT code for the IUD placement. You cannot bill for an E&M service because everything you did that day was related to the IUD. On the other hand, if all contraceptive options are discussed, followed by an implant or an IUD being inserted, you did two different things. Number one is you had a conversation about contraceptive options, about reproductive intentions that you heard about earlier today, about shared decision-making. All those can be billed in addition to the CPT code for the IUD. And so the third bullet basically is saying the same thing. If the patient comes in for another reason, but during the same visit you do a procedure, then you can bill for both. That's what's called a turnaround visit. Janie came in because she was concerned about an STD. She left with a Skylar. Okay, so she came in for one reason. She was counseled and tested for that reason, but she ended up with an additional service, which was contraceptive counseling and her IUD. So we can go for both. Next slide. Okay, now, if we're reporting both an E&M and a CPT for a procedure, what is necessary is that all of the things that we did for the E&M part of the visit is separate from and significantly different than the procedure that we did. And when we take into account that contraceptive counseling and STD counseling, we will use either medical decision-making or total time. But we can't count the time of the procedure, otherwise that would be double billing. So let's say, for example, you spent 20 minutes on counseling and you spent 10 minutes on the IUD, then you can only count the 20 minutes that you spent on counseling in the computation of medical decision-making or total time. You can't count the procedure time, okay? And then you have to use the 25 modifier added onto the E&M code, which says that all this counseling was separate from putting in the IUD. Next slide. Next. Okay. Again, another sidebar, and that has to do with the ultrasound. And here ACOG says that an ultrasound to check for the IUD placement, you know, is not standard of care. It's not recommended by any guidelines. You know, the provider did it just because she wanted to check and make sure the IUD was in the right place. That really should not be billed. On the other hand, if you've had a particularly difficult placement of an IUD, you think it might have a perforation, you think it might be in the wrong place, you think it might be embedded, you think it might be partially expelled, then in that circumstance, you can bill for an ultrasound. But what needs to go into the claim is maybe a copy of your note to explain why that ultrasound was necessary on the same day that you did the IUD placement. Next slide. Okay, so if we were billing before January 1st, the face-to-face time with the clinician for the counseling was 18 minutes. So next, given the fact that Janie was an established patient, next. Oops, okay. Hey, there we go. That would have been a 99213 because she's an established patient, 18 minutes, okay? Next slide. So in the old system, I'm not gonna spend much time on this, the next slide you'll see is how this would have been built, okay? But that's old history, let's go to the new way of doing it. Next slide. And you'll see an updated table in just a minute. So after January 1st of this year, the total time, again, excluding the IUD placement, was 26 minutes. And that 26 minutes was the initial review of her prior history, all the time counseling, typing her note afterwards. It's 26 minutes. Janie's an established patient. So where does that fit? Next. It's a 99213, okay, right in the kind of in the middle of that range. Next. So that's in the new definition of time. Now we might also look at the cognitive part of that visit being billed on medical decision-making, because if that's higher, like a 99214, then we can choose that. And remember, we got to look at three different things. So problems, data, and risk. Next slide. Okay, so she had one acute, uncomplicated illness. That's low. Next. Okay, so that first column of the number and types of problems is a low. Next. The middle column is how many tests we ordered. And we sent samples for gonorrhea and chlamydia. So that can be counted as 1 point for each of chlamydia and gonorrhea. By the way, we cannot count the office pregnancy test or the point of care HIV test. Because we bill for those, we're going to be paid for them. But since that is the case, we can't count them as being unique points in this middle column. Next. Okay, next. All right. Now, the third column, remember, has to do with the risk of complications. And because her IUD is considered to be a prescription drug, then that fits in the moderate category. Next. Okay, so we drop them into the table that I showed you earlier. It's a low number of problems, a limited amount of data, a moderate risk of morbidity. So you can only use the highest of 2 out of 3. So that makes it, for an established patient, next, a 99213. So it turns out that whether we use total time or whether we use medical decision making for the part of the visit that wasn't the IUD insertion, that it came out as a 99213. So here's how we're going to build Janie's visit. The procedure was an IUD insertion. That's the what. The Y was Z30.430, insertion of an IUD. The drug or supply was the Skyla insertion kit, J7301. The reason was insertion of an IUD. The point of care tests that we did were a urine pregnancy test and an HIV 1 and 2. The reason we did the urine pregnancy test was Z32.02, which is a negative pregnancy test. The reason we did the HIV test was Z11.4, which is to screen for HIV. And then finally, the E&M code is a 99213. I told you how to compute that. It has to have a 25 modifier because that goes into all that preliminary counseling. And the reason then is Z30.09, which is family planning advice, and Z11.3, which is screening for an STD. You have to put that because we screened her for gonorrhea, chlamydia, and HIV. So that's how Janie's visit's going to be coded. Next. I know I only have 10 minutes left, but I'll finish the next 2 cases. All right, next case is Betty. She's a 41-year-old established patient seen for a checkup visit, well woman visit. She doesn't have any complaints. She's using oral contraceptives. She wants to continue. You notice that she has a vaginal discharge and you perform microscopy. And it turns out that she has bacterial vaginosis. She's given the option of whether or not to be treated. She wants to be treated. And so she's prescribed oral metronidazole for a week and given some counseling about bacterial vaginosis. The face-to-face time with her was 32 minutes. 20 minutes of that was her well woman visit. 12 minutes of it was managing her BV. And the total time was from the front door to leaving with typing your note was 39 minutes. Okay. Now, again, I know this is a hard case, like the case before it, because it's 2 different things. You're doing a well woman visit, but in the well woman visit, there's also this evaluation of her discharge and bacterial vaginosis. And you can bill for both if you do it correctly. Next slide. Okay, so this gets into a different code set. We haven't talked about this so far. This is for preventive medicine services. Okay, this goes by lots of names. A checkup visit, a well woman visit, a periodic health screening visit. Hopefully you are not using the term annual any longer or calling it an annual exam any longer, because these don't have to be done every year. They can be done every 2 or 3 years, but it's basically a checkup for a man or a woman. The code series that are used, I've listed for you, 99381 through 99397. And in those codes is a comprehensive history, a physical exam, whatever is necessary. That might be nothing, might be a blood pressure check, it might be more than that. Anticipatory guidance and counseling, immunization and labs, and management of insignificant problems. Next slide. Now, these codes are based on 2 things. Number 1, is the patient new or established? And number 2, what's the person's age? Betty's 41 and an established patient. So for her well woman visit, we use a 99396. Next slide. Okay. Now, there are also rules about what if problems come up during a well woman visit. And the rule is that if it's an insignificant or a trivial problem, it doesn't take any extra work to evaluate, you can't bill for that. So let's say, for example, in the context of her well woman visit, when you were evaluating her vaginal discharge, you noticed that she had a hemorrhoid. You said, is this hemorrhoid bothering you? Have you had it for a long time? She says, oh yeah, I developed that after my most recent pregnancy and it doesn't bother me at all. So you can't bill for the evaluation of that, okay? Another point is that when you spend time during a well woman visit on contraceptive management, family planning management, talking about pregnancy intention, all of that is included as well in the preventive medicine visit. So you cannot bill separately for those either trivial problems or contraceptive management issues. Next slide. Okay. However, if it's a completely unrelated problem that you're dealing with, like your vaginal discharge and bacterial vaginosis, then you can count it. Okay, so I mentioned a moment ago that a total of 12 minutes was spent evaluating her vaginal discharge and what ultimately was found to be bacterial vaginosis. And she's an established patient. So what E&M code would you bill for that? Next. Anyway, there it goes. Circle around the 99212. Okay, so that's that sidebar time that we spent on the BV diagnosis, treatment, counseling, and charting. Next slide. Okay. Now, what if we wanted to do this on the basis of medical decision making rather than time? Well, it was a minimal problem, BV, a minimal amount of data. Whatever tests we did, we already billed for. There is moderate risk of complications because we gave her metronidazole, but we can only take the best of 2 out of 3. So next, for an established patient, that's going to be a 99212. Okay, next. All right, so, okay, now that's the what. What about the why? So what kind of code do we use for the well woman visit? And the answer is there's a difference between a general adult medical exam as opposed to a routine GYN exam. A well woman visit is down at the bottom. That's an encounter for a routine GYN exam, okay? And not a comprehensive general adult medical exam. That's what the primary care provider does. Next slide. Okay, so what we're going to do now is put it all together in how we're going to bill for this. Betty did not have a procedure. The drug that she was supplied was metronidazole for 7 days to treat her BV. The reason for that was N76.0 acute vaginitis. It's interesting that bacterial vaginosis does not have its own unique ICD-10 code, so we have to use N76 instead. Point of care lab was a wet mount, 87210, although some payers want the Medicare code, which is Q0111, so be sure to check with your payer. She did have her well woman visit, which is the preventive medicine service for a person between 40 and 64 years of age. The reason for that was a GYN exam with abnormal findings, so that's Z01.411. The abnormal finding was her acute vaginitis. And so we have to put the 25 modifier on the 99212 to say that the evaluation and diagnosis and treatment of her bacterial vaginosis was separate from her well woman visit. And the ICD-10 diagnosis code has to be that N76.0 to show her acute vaginitis. All right, next. We have 5 minutes left. I'm going to try to squeeze in one more case. Skip over that one. And hopefully we'll get to Mary. Okay, Mary's a 30-year-old established client who's been using DMP every 13 weeks for the last 2 years. She called for an appointment 2 weeks before her next injection was due, but really didn't want to come in because of the stay-at-home order. So instead, she had an audio-video telehealth visit, 15-minute discussion with a clinician. She actually decided to try self-injection of Depo Sub-Q, as we talked about a few hours ago. And one unit was delivered curbside to Mary. That should say Mary instead of SB. Okay, how are we going to code for this? Because it's a telehealth visit. As opposed to a face-to-face visit. Next slide. Okay, so this lost a little in translation, but it basically summarizes what you need to know about billing for virtual visits, which another way of saying is either audio-video visits or telephone-only visits. So the first question is, was there video or pictures? In her case, the answer was yes. Was that real time? The answer to that was yes. You know, the clinician and the patient were on the screen at the same time. So that's called a telehealth visit. you bill a standard E&M code and you put a 95 modifier. On the other hand, if there's just a photograph and that's all, and it's like sent to a clinician, the clinician then later sends an answer, then you use a new code for what's called a virtual check-in visit with G2010. Next question is, there weren't any video or pictures. Let's say it was just a telephone call. Was this to determine the need for a visit? If the answer is yes, then we use another brand new telemedicine code, which is G2012, called a virtual check-in. Let's say the answer to that is no. Is the client on the phone? If the answer to that is yes, she is on the phone, this was a telephonic only visit, then we use the code series at the very bottom, 99411 or 4, all the way to 499443. That's based on how much time you're on the telephone. Next slide. Okay, now I want you to, we talked about these earlier, so skip this slide. This has to do with Depot sub-Q, and we don't have enough time to talk about it anyway, but you'll find it in your slide set. Next slide. Again. We'll skip 2 or 3 slides until we get to a table. Skip again. Okay, that's what I'm looking for. So how are we going to bill for this telemedicine visit for Mary? Number 1, there was no procedure. Number 2, she was dispensed a unit of Depot 104 to use at home. So the J code for that is J1050 for DMPA, and there's a lot of detail about how to code for the units. Your biller knows that. The reason for that was Z30.42, which is surveillance of injectable contraceptive, follow-up of somebody who's using Depot. There was no point of care lab because this was a telemedicine visit. The E&M code is 99213, established patient given the time frame for this telemedicine visit. And we have to put a 95 modifier on it. So it's 99213-95 because of the fact that it was a telemedicine visit. Next. Okay, so there was one last twist on Mary. 12 weeks later, Mary called the clinic and said, I didn't like the idea of doing that self-injection. I want to come back and get Depot IM. When she was seen, she was complaining of continuous light spotting over the last 4 weeks. And she spent some time discussing that with the clinician. She had an office pregnancy test that was negative. She was then given her Depot IM injection by a medical assistant. The total time of that visit was 24 minutes. Next slide. Okay, so basically there are 3 ways to bill for an on-site Depot injection, all right? Number 1, patient comes back and says, my last Depot injection was 14, 15 weeks ago. I'm here for my next shot. Patient doesn't see a clinician, the medical assistant or an RN gives the shot. The only thing that you can bill is a 96372. Typically pays about $15 or $20, but no E&M. The second possibility is that the patient is a Depot user, comes in, has a conversation with either a registered nurse or a clinician, and ultimately it turns out that the patient is doing okay. You can either use a 99211, which is that nurse visit, or the injection code, which is 96732, whichever pays better. But what we had today was the third, which is a clinician visit for a Depot shot, but there was management of another problem, which was all this bleeding that she's been having. And it took a long time to evaluate the bleeding, okay? So next slide. Here's how you here's how you bill rather for the visit that Mary just had. Next. All right, so she had a 96372, which is the office injection. Oops, go back. This is the very last slide. There we go. 96372 for the office injection of the Depot. The reason why was she's a Depot follow-up patient. Number 2 is the drug itself, J1050 times 149 units, which is for that model of Depot that you used. Next is that she had a pregnancy test. The reason for that was Z32.02, which is a negative pregnancy test. Now here's the important part. Remember all that time you spent talking with her about her bleeding. That's a 99213, an established patient where you spent between 20 and 29 minutes. The reason was not Depot, the reason was N92.1. It was excessive and frequent menstruation with an irregular cycle, okay? That's what basically justifies billing an E&M and an injection on the same date of service. The thing is that you have to put a 25 modifier onto the 99213, which says that this was more than just giving the standard depot shot. Okay, and the reason why was because of this bleeding problem that she had. All right, next couple of slides, I'm not going to show all of them to you, but they are some important references that have to do with these new E&M codes, and then some of the references that are beyond this have to do with a lot more detail about coding for telemedicine visits that we didn't have time for today. So with that, I will go ahead and stop. Gosh, I'm only 2 minutes over. And if you've got time, I've got time for a couple of questions. If you need to wrap up, that's fine. And my first slide had my email address. Feel free to email me.
Brooke, if you want to stop sharing your screen and go ahead and move on, I think we can take 5 minutes or so for questions while they get set up for the closing. If anybody has any questions for Michael, feel free to type them in the chat here. Give it a minute.
All right. Well, I don't see questions, so.
I don't see anything quite yet. Nope.
Oh, there we go. Down there is download the AMA chart that is in the, I guess it's over in the expo about medical decision making. Way more information than what I gave you.
Yes, there are actually a couple of things you can download if you scroll down below the video that you're watching.
So Megan, back to you.
Okay, so you can actually see a couple of things down below that you can go ahead and download here. They are also available in that Envision booth under the Expo tab. But remember, we will be sending everything out to you after the event early next week. So we are getting set up on the stage area to do a very quick closing. So if you want to navigate over there, just click on stage on the left of your screen. And in just a few minutes, they will be doing, again, a very brief closing statement. But thank you so much for coming today. And thank you to Dr. Policar. And our closing statements will begin in just a few minutes.